Hi everybody, I'm Philip Schnars and I'm an associate professor at Dell Medical School in the Department of Population Health at UT Austin. First, before I begin, I want to acknowledge everybody that was a part of this study, our co-investigators, our community partners, as well as our community advisory board. I also want to acknowledge that this project is funded by Merck. So just a little bit of a background, there's 1.6 million people living in the United States who identify as transgender, and we know that transgender individuals are disproportionately burdened by HIV, and that these differences in HIV rates are particularly relevant in Black and African American individuals, as well as Hispanic or Latinx transgender women. One of the issues that we have is we don't have a lot of data on transgender men or individuals who identify as gender diverse, so non-binary, gender queer. I may refer to them, this group, as gender expansive or gender diverse throughout this talk. And we also have a high prevalence of HIV in the southern United States. So in a recent study, 92% of transgender women were aware of PrEP, but only 32% were currently using PrEP or had used PrEP in the past. So the purpose of this study was to look at preferences and needs in terms of 3 longer-acting formulations of pre-exposure prophylaxis, which are a monthly oral pill, a longer-acting muscular injection, as well as a long-acting implant. This was a CBPR project, or community-based participatory research, so the individuals that you see here helped conceptualize the study, helped implement the study, provided feedback on recruitment strategies, and we're now actually currently working on our next proposal to continue this work. The data that we collected were done, one, through a participatory method called a World Cafe conversation, in which we had community partners, community leaders also co-facilitate some of these sessions with us. We noticed that we had few transgender women who participated in those World Cafe conversations, so in conversations with our community advisory board, we decided to do some in-depth interviews as well with this population. In terms of our analysis, we went through a pretty standard qualitative analysis for this, using structural coding first and then thematic coding within those indexes. In terms of demographics, we had a number of individuals who were gender expansive. We had pretty good differentiation in terms of age, as well as race and ethnicity, although the sample was predominantly white. For those of you who aren't from the United States, that's Texas there, and that's the different public health regions across the state that each have their own sort of unique culture, and those are the number of individuals that we recruited from each part of Texas. So just quickly, I'm going to run through some of these slides because I do have a lot of results to provide. The results that I'm providing, showing here today, aren't all of the results that we have, but only those things that were specific to trans experience or to longer-acting PrEP. And what we found was that there were 4 levels of barriers that included individual barriers, interpersonal barriers, clinic or health system barriers, as well as social and structural barriers. So in terms of individual level barriers, we noted 3 themes that emerged were mental health or psychological distress, physical health or effect on the body, as well as lack of knowledge or awareness. In terms of mental health or psychological distress, one thing that came out was the experience of gender dysphoria that some of these longer-acting formulations may cause. Also, because you get to take the injection in your hip, you have to pull your pants down too, or pull your pants down to get it done, which, like dysphoria for some people, might not really like to do that. In terms of physical health or effects on the body, we noted, especially among trans women of color, that there was a concern about keloids with the intramuscular injection as well as the subdermal implant. That would be something I would like as well, because I'm a melanated woman, and being melanated, a lot of us keloid. Now, I don't think I would keloid, but a lot of people have family who do, so a long-acting implant could leave a mark and it could leave a raised area. Finally, for individual level barriers, we also had lack of knowledge or awareness. I guess there's still a stigma around HIV/AIDS and PrEP. I've come across a lot of people who are just like, oh, you know, you're part of this group, so you're going to get AIDS. And I'm like, no, that's not how it works. I'll educate them, and they're like, oh, I didn't realize that's how it works. In terms of interpersonal barriers, we also had 3 themes. I'm going to go a little bit more quickly because I'm running low on time. Experiences of discrimination and stigma, and there's also problems with medical discrimination against us, where if you're not fortunate enough to live in an area with easy access to a gender-affirming clinic, it can be very difficult to access sexual health care as a trans individual. In terms of experiences of discrimination and stigma, this wasn't just about trans experiences, but also how these different identities interlocked, so really thinking about intersectionality. And so there's just very little information consideration at all for disabled people and for intersex people. I just don't think that people are always, I guess, like intersectionality is not a thing that is centered in medical spaces. And then finally, in terms of medical distrust, individuals talked about distrust for healthcare professionals. For the long-acting injectable, the long-acting implants, one thing I could think about is the distrust of health professionals, especially living in Texas. I mean, so many are fairly conservative, so if you live in one of those areas, you may be kind of reluctant to go to a hospital and to have some sort of injection done, just because of the distrust of healthcare professionals. And then finally, medical trauma in terms of interpersonal barriers. As a trans, intersex, and disabled person, I have a lot of medical trauma. So while in my mind, the long-acting implant is being practical, because I have so much medical trauma, it might be hard for me to do something that was that much of an invasive procedure. In terms of clinic or health system barriers, we noted two themes. The first one was about lack of autonomy in terms of being able to use the medication themselves. And that includes the number of refills, with the oral seeming like the most accessible because the autonomy involved in being able to administer my own medication monthly or even daily. There was also concern over more frequent clinic visits that incurred with the intramuscular injection. Yeah, I live in San Marcos and I have to go to Cedar Park to get my treatment for HRT, and the less I have to go into a clinic and risk encountering someone who is not prepared to work with me in a way that is meaningful or helpful, the better. And then finally, in terms of clinic or health system barriers, we know that there was sort of clinic accessibility and general lack of accessibility for this population. I'm well employed, well insured, but some of my friends are underemployed, and I don't have transportation, so there's a lot of barriers for them. And that's why I keep harping about, let me get this to them in their locations. If I can get mobile clinics with this stuff in there, it's a quick in and out, and you have your medication, versus them having to go to the doctor or a clinic and take time off of the work, which they can't do because they can't afford it. So just some conclusions about this preliminary data that we have. Discrimination and stigma undergird some of the barriers that we're going to face in terms of uptake of longer-acting formulations of PrEP. There's also need for multi-level interventions, things that address all of these different barriers that we've noted. And we also need to rethink how we might be delivering these longer-acting formulations. Is it possible to get them decentered outside of clinics and into spaces in the community? And there's much more research that's needed, especially among trans men and gender diverse individuals, as they've been largely excluded from efforts around HIV prevention and HIV research. Just next steps for this project, we're currently co-developing best practices with our community advisory board and organizational partners for how to engage with trans and gender diverse individuals in terms of research as well as HIV prevention. We're co-developing policies and provider training around reducing trauma in those spaces as well. And we've recently launched a statewide survey that's looking at preferences, needs, and wants for longer-acting formulations of PrEP that also look at these barriers as well that we've noted in this qualitative work. And we've currently recruited about 130 people to complete that survey. These are my references. Thank you so much.